So I'd like to introduce our speaker today, Dr. Kerry Caperell. Dr. Caperell is Division Chief of Pediatric Emergency Medicine at the University of Louisville and Norton Children's Medical Center. Dr. Caperell joined us in 2011 after he finished a residency and fellowship in emergency medicine at Pittsburgh Children's Hospital, where he also completed a master's in clinical research. Since then, Dr. Caperell has also completed an MBA at the University of Louisville. So a fun fact about Dr. Caperell, he was actually a financial analyst prior to going to medical school, and did some work as a retirement plan administrator while he was in medical school and residency. So thank you, Dr. Caperell, and he will be talking about emergency department evaluation of common pediatric problems. So welcome, Dr. Caperell.
Thank you, Dr. McDonald. Nice to see you, and thanks everybody for coming. I have no relevant financial disclosures, and Dr. McDonald just sort of briefly reviewed my background and that retirement plan stuff you can see at the bottom. My other fun fact is that my primary degree is actually in economics, not a traditional science that one goes into medical school with. But at any rate, I still enjoy that aspect of things and the business side of things. And I just want to, have an opportunity to, or give you an opportunity to reach out to me. That's my cell phone number right there. Why don't you copy it down, or if you want, go ahead and send me a text right now and introduce yourself. We operate 3 emergency departments here in the city, and I would really like the opportunity to hear from you and talk to you about any questions or concerns or things we can do to enhance pediatric ED care for your patients. So please feel free to, somebody just did reach out to me. Feel free to reach out to me and talk to me whenever you want. I'll ask McKenna to put that number in the chat in case you didn't copy it down. All right, so there's a couple of poll questions that I asked McKenna to help me with here just to keep this interesting. So I want to know where you trained, first of all, if you trained here or if you trained somewhere else. Looks like I have to answer it too. So I'll give that a moment. All right, so it looks like, wow, 50-50, really right on the nose. That's pretty impressive. Okay, so half of people trained here in Louisville and are perhaps familiar with, how things have been done here traditionally in the city, and others, have formed their views of how things are done based on training elsewhere. So the next question is, what decade did you complete your pediatrics training? Give that a moment. Hope everyone's paying attention. All right, so it looks like quite a few of you trained, let's say more than 10 to 20 years ago. And I think this talk will be especially relevant because we're really going to talk about some things that have changed just in the last few years in how we manage some of these conditions. And then this last one, if you have a fun fact, and I already sort of gave you mine, go ahead and put in the chat box, although I actually can't see the chat box, so I can't monitor that, but go ahead, I guess you all can look at them. All right, so again, why are we doing this? Really the reason is because evaluation and management of pediatric patients, all patients, evolves, and it's useful to know, for you to know what your patients can expect when they come to our emergency department. You can help us with setting expectations. You can anticipate maybe questions that they have and understand the answers. And really, we're in partnership with you on this. So if you understand what our current management is, it's really going to help you and us take better care of your patients. So these are the learning objectives for this talk. You can see them there quickly, and these were already provided to you, but we're going to basically talk about abdominal pain, febrile neonates, and bronchiolitis. But I actually changed the order of how I did this. And the reason is I think the evaluation is much more straightforward and clear cut for a febrile neonate than it is for bronchiolitis, for example, with abdominal pain sitting somewhere in the middle. And the reason for that is that, you know, the febrile neonate is objective, and we have a bunch of objective findings, mostly the fever, whereas bronchiolitis has a lot more subjective component to it. And so I've changed the way we're going to talk about this. So I want to start off easy, and that's with fever. And again, we're talking about febrile neonates. You know, and one of the questions that we sometimes have to answer is it even a fever? And I think you folks know this, but, you know, where the thermometer goes is somewhat important. You know, frankly, if somebody reports to me that they did a forehead or an ear temperature and they had a temperature of 101 or 100.4 or greater, I'm going to evaluate that just as I would a rectal temperature. Again, if they have a fever at home, but they come to your office and then they show up in my emergency department and they don't have a fever, what do I do with that? Well, for me, in the way all of the literature has been done in the past, that still counts, so to speak, as a fever. And then what if the fever is 100.3? You know, what do we tend to do with that? And for the most part, we're just going to observe those kids. Make sure they look well, check vital signs for a couple of hours serially, including temperatures. And if after 2 or 3 hours, they're still a febrile without any antipyretics, we will usually let them go. That's not really what this talk is about. So let me propose a case to you. And again, you're going to have to answer a question. So you have a 35-day-old girl who was born full term and who had a fever to 102 taken rectally. Suppose this was in your office, it was 102. No localizing signs or symptoms, vital signs were stable, and she's well appearing with a normal exam. So you say, well, you need to go to the emergency department. You're a baby, a neonate with a fever. What will they do in the emergency department? Or what will we do in the emergency department? I'll give you a moment here to consider. I cannot see the chat actually. All right. So looks like we're pretty 50-50 on this 35-day-old, with half of you saying we're going to do a UA urine culture, CBC, and blood culture, and about half of you saying we're going to do those things plus a lumbar puncture. So, and again, I don't know if anybody put anything interesting in the chat, but let's just go with that, because that's kind of what I wanted you to say. And we probably should have seen how it's split out based on when you trained. That might have been interesting. You know, the care of these febrile neonates has evolved. There's new testing that we do. There's immunization now against pneumococcal disease, and there's new data that's come out even just in the last couple of years. And why has our practice evolved? Well, we want to reduce unnecessary testing. We want to reduce unnecessary hospital admissions. And so this is an algorithm, and I'm going to focus in on different parts of this, so you don't need to take the whole thing in all at once. You will note that this algorithm was just revised in June of last year, right in the middle of the pandemic. We're going to slowly focus in on parts of this. I'm going to walk you through what we do and why. So we're going to start up here. I'm going to blow this up. So that first box that's in that yellow orangey color, this one, if you can see my pointer. So if a child is ill appearing or not breathing well or doesn't have good circulation or has some chronic illness, no matter what, they're considered high risk, and they get the blood, urine, and lumbar puncture. Moreover, if a child is less than 28 days old with a fever, they're also high risk, and we'll get that full evaluation. It is in this purple box, the children who are 29 to 60 days old, that's where things have changed. And again, this was June of last year that we formally adopted this algorithm. So back to the whole algorithm. Now we're going to walk back through sort of what happens in these children who are 28 to 60 days old. All right. So we're going to start with CBC, blood culture, UA, and urine culture, and then this thing in the middle, procalcitonin, which has been around for a while in various instances. And just to review, procalcitonin is an acute phase reactant that's produced by monocytes and hepatocytes. Expression increases several hours after exposure to bacterial endotoxins, and levels remain elevated for at least 24 hours. And so this has been looked at as a marker for bacteremia and sepsis. And that's why it's important. And so it was so important, and you can see this article was in JAMA Peds in February of 2019. And this data was published through this Pediatric Emergency Care Applied Research Network, what we call PECARN. This is a NIH-funded national consortium of pediatric emergency departments. And so they did a prospective trial looking at febrile infants younger than 60 days and tried to come up with a rule for basically who you had to do a lumbar puncture on. And again, this is again about procalcitonin. This is from that article. Procalcitonin is particularly sensitive for detecting bacteremia and bacterial meningitis in young febrile infants and is widely available for clinical use, requiring only 200 microliters of serum and having a turnaround time of 30 to 120 minutes. Not only is the test accuracy of procalcitonin substantially better than the white blood count in A and C, but it also surpasses that of C-reactive protein. The better test characteristics of procalcitonin versus CRP is perhaps owing to the earlier rise in procalcitonin in response to systemic infection. Okay, so these authors, and I'm going to go through this a little bit more, but they thought and believe based on their data that procalcitonin is an important marker for sepsis. All right. So getting back to this algorithm, because remember we did urine, blood, and procalcitonin. So children categorized, and again, these are 29 to 60-day-olds, categorized as low risk have a normal urine, a normal ANC, and a normal procalcitonin. Everything is normal. So those kids who look well go home. And we ask that they follow up with the pediatrician, the next day. So that's a big change from when I trained. I finished residency in 2008. And from when many of us trained, where a 35-day-old with a fever of 102, like the one we talked about, we didn't do procalcitonins then, but they all got lumbar punctures and they all got admitted. And again, normal procalcitonin. All right. There's an intermediate risk category as well. This is taken directly from that algorithm. Okay. So again, the procalcitonin is normal, but the ANC is greater than 4,000. All right. In that case, you really have two options. One is to admit them, get an LP and observe them either on or off antibiotics, or admit them, not get an LP and observe off antibiotics. That's this first box. The other box here sort of tries to help you stratify the risk further by looking for other causes of fever. And if you find them, consider sending the child home with or without a lumbar puncture, with or without antibiotics, with close follow-up assured. So this intermediate risk category, I will say, is unusual. Usually they're low risk, but then the rest of them are high risk. We don't see the low or the intermediate risk too often. But this is sort of where, experience and comfort level of how the child looks and with the family really comes in, far more so than in the other circumstances where we have a clear path to follow. All right. High risk is when the other labs aren't really relevant. High risk is when the procalcitonin is high. And these children get treated the same way we used to treat them, the same way we treat somebody during the first 4 weeks of life, which is we've already gotten the blood and urine, now we're getting a lumbar puncture, we're starting empiric antibiotics, and we're admitting the child to the hospital. And then there's this other category where they have an abnormal UA, which in the way we look at it is as positive nitrites, bacteria present or there's greater than 10 whites, and we would only do these as cath urine, so pretty reliable for those categories. If the procalcitonin is normal, we don't need to do an LP. If the procalcitonin is high, we would do an LP in that case, okay? And then after that, those children would be started on antibiotics and admitted to the hospital because they have the SBI, serious bacterial infection, the UTI. All right, so this is that study, the JAMA PED study that we talked about, where they used procalcitonin. And they basically, the algorithm that I just reviewed mirrors what was done in this study. So there were, in their validation set, 63 or 638 children greater than 28 days old. And they found their rule, the algorithm we just reviewed, to be 97.7% specific and 60% or sensitive, 97% sensitive, 60% specific, right? And you may remember those are, in statistics, sensitivity and specificity are characteristics of the test. They don't change based on the population. And then in their validation population, the rule had a 99.6% negative predictive value for SBI. And that is a characteristic of the population. So in their population, 8.2% of the children had an SBI, and of those, they missed 2. We'll talk about that in a second. Because this study was based on a sample of emergency departments across the country and was gathered prospectively, it's very powerful, and we think, and this is the collective we pediatric emergency medicine people think, that this population mirrors our own population. So it's a good rule to apply in our population. So, you note that it's not 100% sensitive, that it's not, the negative predictive value is not 100%. So what happened? So they missed 2 children who had a UTI. Both of those kids had a negative UA. And then they also missed 1 child who had a positive blood culture, which appears to have been a contaminant, as a repeat culture that was done prior to the child getting antibiotics was negative. Either way, all of these kids had an uneventful course. So that's pretty powerful stuff, and that's why this isn't just locally, this is sort of, this wave has swept the country. This is why we do the evaluation of febrile children greater than 28 and less than 60 days in this manner. And notably, those test characteristics outperform the criteria we all learned when we trained. So Philadelphia, Rochester, Boston, I was in Pittsburgh, was a Pittsburgh criteria. It outperforms all of those. It's a better rule, a better algorithm. All right, so what will they do in the emergency department for this patient? Well, it's obviously the something else, because we would do the first 2, A and B or whatever, and then we would do a procalcitonin in addition. There you go, what I just said. All right, so what does this mean? This stuff takes time. And so when you send a patient to me in the emergency department that falls into this algorithm, they're going to be in the emergency department for a little bit because we have to get the data back. It's interesting that the machine we do the procalcitonin on, it gets calibrated every night. So if it's the middle of the night, it might be delayed another hour or 2 while that's going on. The babies are going to be in the ER for a bit. We don't LP every single one of them. We don't give antibiotics to every single one of them. We don't admit every one of them. And the ones that we don't admit, that we discharge, we rely on you for close follow-up. All right. So as I said, that was the easy one, right? Because we have really good data and we have very objective measures of everything. We're going to move on here to abdominal pain. I can't remember who told me this, but they said that it's the ultimate undifferentiated complaint and the most challenging and time-consuming for the ED physician to evaluate. From my perspective, there are 3 possible outcomes to this emergency department evaluation. You show up, I see you, I either know your diagnosis and you're having an emergency and we need to admit you, do an operation, give antibiotics, whatever it is, Or you show up, I see you, I figure out what your diagnosis is, but it's not an emergency, and you can just follow up as an outpatient with pediatrician or GI or whomever. And the third, and perhaps the more common of all of them, is I'm not exactly sure what your diagnosis is, but it doesn't seem to be an emergency, but you can safely be discharged and you'll need to follow up. So those are the possible outcomes, and we see those outcomes, commonly every day when we're working. All right, so why has the evaluation of abdominal pain changed? It's really to reduce unnecessary testing, particularly CT scans, and to streamline the way we do a workup that's really frequently performed. So this is from Fleischer and Ludwig, and I'm just showing this as an example. So Fleischer and Ludwig is the textbook of pediatric emergency medicine. It's our Nelson's. And this is just a portion of a table on one page that shows me all the causes of acute abdominal pain. And I don't know if you can appreciate, but it kind of keeps going. It actually goes on for 3 pages, and I'm not going to show all of that. My point here is that abdominal pain has a broad differential diagnosis. And then same textbook, they try to tell me the 30 or 40 things that I would need to figure out immediately because they're life-threatening causes of acute abdominal pain. Again, very broad: ectopic pregnancy, aortic aneurysm, incarcerated hernia, all these different things that can cause abdominal pain, acute abdominal pain that could be life-threatening. And then it tries to break this algorithm down. You can see, and this again goes on for 3 pages. It just kind of, continues on and on and on and on. Very challenging. And so this is really something that we wanted to streamline. So we have a poll question though. So frequently we get sent patients or see patients who were concerned for appendicitis. So what is the gold standard for the diagnosis of appendicitis? We'll give that a minute or two, or a few seconds, I guess. I just made my vote. All right, gold standard. So a third said physical exam, a little over a third said CT, and then some folks thought some labs and ultrasound. And so all good guesses, but you probably guessed that it's not going to be quite correct. So, I asked, Cindy Downard is our chief of surgery here, chief of pediatric surgery. So what is the gold standard for the diagnosis of appendicitis? And this is her quote to me: "The true gold standard by which all else is measured is final pathology." It means you do the operation, take the appendix out, slice it up, and look at it under a microscope. She said the diagnostic workup, sensitivity, and specificity varies with different numbers reported for CT, ultrasound, and history and exam in every study. It often depends on the training experience of the person doing/reading the exam or study. And that is very true. We'll talk a little bit more about that. So we can't operate on everybody, right? We can't just look and say, it's appendicitis, or you have a bellyache, you need a CT scan, or you need an operation. We're going to take out your appendix and look, right? We can't do that. So CT scan is maybe the next best thing. This is from a Cochrane review from a couple of years ago. It's 95% sensitive and 94% specific. That's for appendicitis. Okay, that's pretty good. And that's actually an appendicolith there. So that one's pretty obvious to read. You can probably see that on a plain x-ray actually. But at any rate, so why not just do CT scans on everybody? That's an interesting question. So this is a study that came out, I think in February of this year, and it's a pretty good one. So risk of hematologic malignant neoplasms from abdominal pelvic computed tomographic radiation in patients who underwent appendectomy, which is a mouthful. It was a Korean study, and they did a retrospective look over many years of everyone in their system that had an appendectomy done. And they compared the group from the appendectomy group. So they all had appendicitis. They compared the group who had a CT prior to their appendectomy to the group who did not have a CT after that, their appendectomy. So basically, did they have a CT scan and then get their appendix out, or did they just get their appendix out? Okay. That's what they looked at, and this was all comers, adults and children. And so this is from their discussion, and I highlighted the part that I think is important. The carcinogenic risk from abdominal pelvic CT radiation was most pronounced in patients 0 to 15 years. And the risk ratio was 2.14. So, and it was mostly leukemias, not solid tumors. It was mostly leukemias, but basically you are twice, the group that got a CT scan prior to the appendectomy was twice as likely to develop an oncologic process, mostly leukemia, was twice as likely to develop that at some point in their life compared to the group that didn't get a CT. That's really profound data if you're me, because you see a lot of kids with belly aches and I got a CT scanner right down the hall, right? So I really need to be thoughtful about who I'm scanning and to try to minimize that, because I could be ordering a lot of CT scans, and doubling someone's risk for leukemia certainly isn't consistent with what I want to be doing as a doctor. So that's why this is important. So again, we have this appendicitis evaluation algorithm. This is from 2019. All right, and the same, we're going to do the exact same thing. We're going to break this down into pieces. Stay with me. So we're going to start up here. So notice that first blue box says abdominal pain with concern for appendicitis on H&P. So that means they have to be telling me the right story. The story can't be that I haven't had a bowel movement in 2 weeks and my whole belly hurts. That's not appendicitis. We don't think about it that way, and I would approach that differently. So it has to be a consistent story. And then what we do, again, it has to be a consistent story, is calculate this MPAS. Okay, and MPAS is up here. I'm going to focus in, right? Am I focusing? Yes, I'm going to focus in on it. So MPAS, Modified Pediatric Appendicitis Score. All right. And we're going to calculate that based just on the history and physical exam items. So the things above this red line that I put here. So do they have a history of, so these are all things that we would think of as classic history and physical exam items, classic for appendicitis. So they have anorexia, they have a fever, they have nausea or vomiting, do they have migration of their pain, right? We usually think periumbilical or right lower quadrant. And then on exam, do they have perineal signs like rebound? And do they have right lower quadrant tenderness? All right, and you can see points are assigned to each of those. So right now we're only looking at what's above the red line. All right, so from an on that portion, there's 8 possible points. Okay, if the score is 7 plus, 7 or more, we're going to do these labs, CBC and CRP, and then we're also going to call surgery in that case. Because the idea is that this sounds like a classic story, history, and exam for appendicitis. Surgery should just come and lay a hand. If the MPAS score is 0 to 3, again, just based on the history and exam items, we do the labs. So we do these, and if that gets them up over 4, we're going to do an ultrasound of the right lower quadrant. Okay? If the score is 4, really 4 to 6, we're going to do the labs again, and we're going to do this ultrasound of the right lower quadrant. All right? The reason we're saying ultrasound, of course, is because there's no ionizing radiation there. We don't want these kids to wind up with leukemia. All right, so this is from a study that really looked at bedside point of care ultrasound for appendicitis, but the numbers are pretty similar for when the radiology does the ultrasound, which is how we do it here. We would send these children for formal ultrasound with our ultrasound techs. So the specificity is high. If you see an abnormal appendix, it's appendicitis, but the sensitivity is all over the place. So you can see here, positive ED point of care ultrasound is diagnostic. However, a negative ultrasound is not sufficient to rule out acute appendicitis without the use of, and it says CT scan or MRI. The sensitivity really varies based on the habitus of the child. So children with more adipose tissue are more difficult to get to the appendix, essentially, when you're looking with ultrasound. It also depends on how good the ultrasonographer is, how familiar they are with this particular study. Ultrasonography is like any other skill. The more of them you do, the better you get. And so we have some ultrasonographers who do this study more frequently and have done it a million times, and they're better at it than those who are novices. All right. So we've walked through, and we're over here now in really what these ultrasound results are. Okay. So these ultrasounds are graded. I don't know where this grading system came from. I believe it's internal. So we have grade 1, grade 2, grade 3. Grade 1 is a normal appendix is seen. So that means we saw the appendix, it looks fine. We PO challenge a child, they're walking around, we discharge them home, hope they follow up with you in a day or so. And explain to the family reasons to return, of course. That's grade 1. Grade 3 is we see appendicitis. So we found the appendix and it's abnormal. And in that case, we're obviously going to talk to surgery and defer to them, and they'll do, what they do, of course. Grade 2 is the most common finding, which is we don't see the appendix essentially. When that happens, we get a surgical consult. And then surgery tells us what to do. So they might say, we're going to admit this child to the hospital. We're going to do serial abdominal exams, maybe repeat an ultrasound in 6 hours or a day or whatever, and see if this evolves. Or we're going to discharge them and we'll see them in 24 hours. Or just go ahead and do the CT scan. We don't know what's going on. All right. Now I will tell you this discharge with the 24-hour surgery follow-up, I've never actually seen them do that. So it's usually either one or the other. They're either going to admit the child and see what happens, or we're going to do a CT scan and hopefully get a reasonably definitive answer in that case. So what does this mean? Again, abdominal pain, it takes time to evaluate. You see, we go and see the patient, and we're going to get some labs. Then we're getting an ultrasound. Then we're going to talk to surgery. And then maybe we're getting a CT scan. It takes time. Okay. So they're going to be in the emergency department. Not every patient is going to have a CT scan that comes in for evaluate for appendicitis. I will tell you in the last year or so, really since this algorithm kind of rolled out, 15% of patients evaluated here for appendicitis actually have appendicitis. So that means 15% of patients who go into that algorithm that we just reviewed wind up spitting out with appendicitis at the end. 65% of patients evaluated for appendicitis are discharged from the ED, which I think is pretty good. So 2/3 of the kids that, again, enter that algorithm wind up going home. All right. We made it. So now we're going to move on here to the last thing I want to cover today, and that's bronchiolitis. So of this one, of the 3 things we were discussing today, I think this is the most challenging to pin down because the severity is a continuum, and the way we quantify what that severity is, it's just, in my opinion, the tools are very coarse. So why do we even have an algorithm? So we're trying to predict which children need to be admitted, which children need to go to the ICU, and also when it's safe to de-escalate care, which children have been admitted and are better enough that we can start taking things away and trying to normalize them. All right, here we are. What will they do in the ED? This is another poll. Might be the last one. So we have a 14-month-old boy, 1 day of increased work of breathing, no fevers, he's feeding well. On exam, he looks okay, but he's breathing 48 times a minute with subcostal retractions and an expiratory wheeze. Pulse ox is 95%. What are we doing in the ED? Give you a few seconds to answer that. All right. So 20% suction, 17% suction albuterol, 17% suction albuterol chest x-ray. A third of you, looks like the majority, went with suction albuterol chest x-ray and RPP, and then 13% said something else. I can't see the chat, unfortunately. Oh, hold on.
No one's typed in the chat, so if anyone wants to enter their responses.
Okay, fair enough. So something else, but they didn't want to suggest what it was, I guess. That's fair. All right. So Well, it turns out we have this bronchiolitis score that looks at respiratory rate, retractions, auscultation, feeding activity. And I'm going to go through this so that you understand. So here's this very subjective or mostly subjective bronchiolitis score. All right. You can see that part of it varies based on the patient's age. Younger children have different respiratory rate requirements. That's what these are. Whoop, sorry about that. Than older children. All right. So, and when I say it's subjective, what I just highlighted there in yellow, is it end expiratory wheeze or greater than end expiratory wheeze? And some of this stuff is just very hard to really pin down, and the reliability of these scores is not as great as I would like it to be. Okay, but at any rate, this is really the best tool that we have, this bronchiolitis score. So the child we just talked about was feeding well, looked well, breathing 48, subcostal retractions, and expiratory wheeze, right? So we do this score, and so you can see 0, 1, 2, 3, 4, 5. So he would get a 5 on this 1 to 12 bronchiolitis score. Does everybody see that? I hope. Leave that up for a second. All right. So we categorize bronchiolitis based on that score we just did. So mild is they don't need any oxygen and the score is 1 to 4. Moderate is the score is 1 to 4 and they need oxygen, or the score is 5 to 8, that's off oxygen, and then severe is 9 to 12. Okay. And these categories help us to an extent decide what we need to do. And so here's this part of this algorithm. This one actually takes up several pages, I think, because of the complexity of the underlying and subjectiveness of the underlying condition. All right. So, but basically, and what would happen in this patient's case, we calculate that score, it's 5 or higher, we suction, and then we recalculate. And there's sort of a lot of this reassess, recalculate, and adjust your interventions throughout this algorithm. You can see down here, it says again, excuse me, reassess, recalculate, adjust interventions, what I just said. All right, but this is sort of the first branch point, right? So after suctioning, so this is, you've calculated the score, you've suctioned them, and you've recalculated. So if they're mild, you can we watch all of these kids for a bit, look at their pulse ox, suction them again if they need it, but hopefully they're able to feed well, and that's sort of the pathway to discharge. If they're moderate, again, we check their oxygen, we do more suctioning, and we do fluids, and if they're not able to tolerate PO, and then if they're severe, again, same thing, pulse ox, suctioning, consider albuterol treatment, consider high flow nasal cannula, and IV fluids if they're not able to stay hydrated, or if we're worried about impending respiratory or airway failure. So consider albuterol treatment is interesting because up here in the corner, this is on that main algorithm, it says evidence does not routinely support, and then it lists these things out. I'm going to make this big. So it's essentially don'ts, right? So if they have what we call severe bronchiolitis, based on that score, we're supposed to continue albuterol, but we also say don't do albuterol. And we also, these other don'ts, antibiotics, albuterol, chest x-ray, chest physiotherapy, hypertonic saline, any sort of labs or semic epinephrine or steroids. And I will tell you, in emergency department literature, hypertonic saline and steroids have been looked at over and over and over again. Different steroids, different routes, different concentrations of hypertonic saline, 3%, 7%, 9%, 6%. That just periodically gets looked at from an emergency department perspective. None of it's been found to help very much at all. That's not to say that these aren't important parts of ongoing therapy potentially. But really, I wanted to focus on albuterol because our own algorithms suggest that we consider albuterol, but it also says evidence does not support routinely using albuterol. All right. So when do we think about albuterol? I think the times when I think about it, at least, is when there's a family history of wheezing. The child's an atopic child, so has eczema underlying, is on the older end of the spectrum, so a 3-month-old, I'm less likely to try it compared to a 22-month-old who maybe has bronchiolitis and is really sick. And the other thing is if there's something documented from prior visits that the child's had respiratory illness before that's responded well to albuterol, then I suppose I would try it then. But in my opinion, it's overdone and it's not usually very helpful. All right. So we've calculated the score, we've suctioned, we've intervened, we've reassessed, we've done all these things, right? The child's been in the emergency department for a while now. So now what do? So we can discharge them home. The bronchiolitis score is up through 8, so less than 9. If their blood oxygen level is okay, if they're not having apneas, and if they're feeding adequately and not dehydrated. And you know, the big one is that we're confident the family is going to show up for follow-up. We really do think that's important in all emergency department visits, particularly in these cases. These children are higher risk, right? If the score is 9 to 12 after we do all these interventions and reassessments, those are the kids we think about bringing in along with obviously hypoxia if they have a history of apnea, dehydration, poor feeding, or frankly, if we think the family's not going to follow up. And then some of these kids wind up in the PICU. So these are the ones that have persistent respiratory distress despite appropriate oxygen or high flow nasal cannula. They deteriorate while they're in the ED. We observe them having apneas. They look toxic. You know, these sorts of things, they're obvious sort of for the ICU. Those patients go to the ICU. So again, consider discharge home. Those are the criteria. Consider admitting to the floor with those criteria. And then consider PICU admission. All right. So I wanted to talk a little bit about high flow nasal cannula in this setting. And I'm going to make this bigger. Yes. Right. So we start at 1 liter per kilogram per minute of flow, and we'll titrate that up to 2 liters per kilogram per minute of flow to try to make the patient better. Once we get past 2 per kilo, those children all need to go to the ICU. So the sort of limit of tolerance for taking care of these patients on the general floor is 2 liters per kilogram of flow. All right. But we can't just put them on it. You kind of have to leave them on there for a bit and then reassess them frequently and decide how well it's working. All right. So again, we start with 1 liter per kilogram per minute of flow, and we titrate flow to response. And response in this case means the respiratory rate's coming down, work of breathing is improving. To a lesser extent, the pulse oximetry is doing better, although it only really helps with that at higher levels of FiO2. The other thing with high flow nasal cannulas, it's not you put it on and they immediately get better. It takes 10 or 15 minutes for the child's physiology to adjust to the flow, essentially, for us to know if it's helped. So we do all that, then we observe them and see if they're able to maintain their response on whatever flow we have them on. And then again, some of these kids, if they get up more than 2 liters per minute per kilogram per minute, we wind up admitting them to the PICU. All right, and so just to help you understand a little bit about how difficult this is to care for, this is a case I had 2 or 3 years ago, 2 years ago, I don't remember, it was pre-pandemic. So I was at NCMC, Norton Children's Medical Center out in Brownsboro by Costco there. I had an 18-month-old girl, she had bronchiolitis. Nice family, kid looked okay. I scored her a 10 initially because of her work of breathing and her respiratory rate. Mom was actually an anesthesiologist. We talked through everything, started her on high flow nasal cannula, titrated her up. Our practice at NCMC, it's a 16-bed ER. You're kind of right there in the middle of things. I reassessed her frequently. It wasn't terribly busy that afternoon, I remember, or evening, whatever it was. But at any rate, I eventually had to titrate her further up to 3 liters per flow, and she improved. Her bronchiolitis score went down to 5. I called the PICU, and we called for JFK transport, and they were on their way there. And I continued to reassess her because it still wasn't busy. And then she abruptly deteriorated out of nowhere. Her respiratory rate went up to 88. She was retracting everywhere. And I intubated her, and she wound up in the PICU for 3 days and then went to the floor and eventually went home. So the story had a happy ending. The point is, this child was only in the emergency department for 2.5 hours total. And they went from, can I go back? They went from sort of looking okay-ish to getting intubated. Bronchiolitis just, it's a very challenging disease to nail down. Some of these kids get abruptly worse, and it's just hard for us to know which ones it is going to be. So what does all this mean? Sicker patients spend more time in the ED to determine the appropriate disposition, like we just talked about. Most patients will not get labs, x-rays, or any kind of medicine. And then some patients, again, their care will be abruptly escalated and de-escalated in the emergency department, as we just discussed. All right. So in conclusion, emergency care is always evolving. Remember, not every febrile infant's going to get an LP. Not every rule-out appy gets a CT. And bronchiolitis can be puzzling to care for. Also remember that we're available in our emergency departments 24/7. You can call us in the department and you can get a doctor to talk to you, one of our fellowship trained PEM providers. And then again, there's my number again. Please call or text me. Text me now to introduce yourself. I'd love to hear from you if you have any questions or feedback. Thank you all for your attention. Are there any questions on this talk?
All right, thank you, Kerry. We have some questions. First question, can you comment on a baby with a low temperature and the current recommendations for what temperature warrants further evaluation?
I can. So we're actually looking at our experience here over the last couple of years with a so-called hypothermic baby. And there's some data coming out around the country, again, emergency department data. Other people are looking at this as well. So for most of us, we look at 96.5 Fahrenheit or lower as hypothermia. And, you know, the reality is we're still combing through the data, but it appears that we do a lot of testing on these children and they're all fine. The ones who aren't fine are not the 2-day-old or 3-day-old who's 96.2 in your office. They probably have a reason to be hypothermic because they're little babies. It's the 3-week-old who's hypothermic or the 2-month-old that's hypothermic. Those are the kids that wind up having serious pathology because they really don't have a good reason for it. But for the most part, these children in the first several days of life, they get hypothermic, they're all fine. And there will be, I suspect, in the next year or two, further guidelines coming out about how we should evaluate those children.
Okay, next question. Can you comment on why rhinoenterovirus is listed specifically in the physician discretion section, which seems to be an exclusion for home care, and it's in the febrile 29 to 60-day-old part?
Yeah. Yes, that is because it is the thing that is most frequently positive, and we actually see plenty of positives in children who don't have fever. And so I think most of us are not willing to, and as a group, we sort of decided we're not willing to chalk up the fever to rhinoenterovirus infection.
All right, next question. Comment on the don'ts that you listed. So if you don't use albuterol, do you use any respiratory treatment? And if so, what do you use?
I'm going to go back to don'ts. There we go. No, we don't use any respiratory treatment. That's the answer to your question. So in general, the data does not support this. So when I was training, racemic epinephrine was a big thing. People thought that helped. But, you know, further study has just revealed, at least in the emergency department setting, and I fully understand that some of this stuff is different in the intensive care setting or the general medicine, you know, admitted setting. But in the emergency department setting, these things don't affect any meaningful outcomes, you know, which for us is, you know, deterioration of disease, need for admission, need for ICU, you know, ability to discharge, those kinds of things.
Yeah, good point. And even with the chest PT, that's only been shown to be effective in intubated patients. Although, you know, granted, we have our situations where we see it effective. Next question. Are you doing an appendicitis study with antibiotics only and no surgery?
Yeah, so that's been looked at. That study is, I don't believe, any longer active. I don't know that they ever wrote up so we participated. It was really the surgeons that drove this, but they participated in it was a national multi-center study. And I don't know that I've seen it published yet to see what the final outcome was of that. But that is something that was ongoing for several years.
Okay. Are the algorithms available to share, or are they proprietary?
They are available on Nsight. And so those of you who are part of Norton Children's Medical Group, they're certainly available for, they are not proprietary. I mean, if you send me a text or something, I'll figure out how to email it to you or text it to you or whatever, that's fine.
Okay. They noticed that there was no urine testing in the appendicitis algorithm. So do you check urine in those patients?
Yeah, absolutely. It's just not part of the evaluation for appendicitis. It used to be, because you used to think about it in terms of some, especially girls, would get sterile pyuria with appendicitis. But now we're checking, so in girls, make sure that they're not pregnant because we don't want to miss an ectopic. And then, to look for possible UTI, but we're not really looking for appendicitis in that case.
Right.
We do check their urines, as the answer to your question.
And then are there any new pathways under development?
So the big one that's going to be coming up next is to more formalize how we treat asthma in the emergency department, and really fold that into the inpatient asthma pathway. So sort of utilizing the same, it'll be a similar structure to the bronchiolitis pathway. I think a little more straightforward because the scoring system has somewhat less the PRAM score, somewhat less subjectivity to it. But basically, guiding how aggressive our interventions are based on how severe they are.
All right, it looks like those are all the questions. So thank you, Dr. Caperell.
All right, great. Thanks, everybody.